Hello, good morning, everyone. My name is John Lucas. I'm a fourth-year medical student up at VCU in Richmond, Virginia. I'd like to thank you for allowing me to come and give this talk that we've entitled Morbid Obesity in the EFAST. It's a pleasure to be here. We have nothing to disclose. So EFAST stands for Extended Focused Assessment with Sonography for Trauma. It's a very common test done in trauma bays across the country to assess for injuries that can lead to rapid deterioration of patients. It's now replaced diagnostic peritoneal lavage in the ATLS algorithm. So our EFAST is our traditional FAST exam with the abdominal windows plus the addition of 2 thoracic windows to assess for pneumothorax and hemothorax. Data shows it to be highly specific, but the variability across the country shows that the sensitivity varies widely, from 20% to 90%. So here's 2 representations of what we see when we do the EFAST exam. On the left side of your screen is going to be your thoracic window looking for pneumothorax and hemothorax. On the right side of your screen is going to be an abdominal window looking for intra-abdominal bleeding. So we know from doing these tests in the trauma bay that a good EFAST exam requires good sonographic windows. And we know that these windows are very hard and harder to obtain in patients who are obese. So we hypothesize that there's a certain BMI at which the risk for incorrect EFAST results increases significantly. Closer. So we performed a retrospective review of major blunt trauma activations at VCU Medical Center, which is a level 1 trauma center. We included adult patients who had EFAST in the trauma bay, as well as CT chests and abdomen and pelvis. And yes, it is protocol at our institution to essentially pan scan everyone who is hemodynamically stable. It's important to note that we did manual chart review on all of this. Not only did we need to collect our EFAST and CT results, but we also needed to collect things such as demographics of the patients, injury mechanism, as well as vital signs. Our EFAST was mostly done by our emergency medicine colleagues under the supervision of their attendings. We then did CT test as the gold standard when looking for the 4 major injuries that we were looking for in the EFAST, which were free abdominal fluid, pericardial fluid, hemothorax, and pneumothorax. We performed descriptive and comparative statistics on our data. We also performed univariate analysis to determine the association of false positive or false negative EFAST results, not only with our BMI levels, but also with the data that we collected that I previously mentioned, demographics, trauma mechanism, hemodynamics. So what did we find? In 446 patients, our EFAST was correct in 340 of them, giving us an accuracy of 76.2%. Our sensitivity was 27.1%, our specificity was 91.7%, positive predictive value 50.9%, negative predictive value 79.9%. When looking at our comparative statistics, we did not find any statistical significance when looking at the accuracy of the FAST exam when it comes to age, gender, shock index, or injury mechanism. When looking at our univariate analysis here for the abdominal component of our EFAST exam, we saw that at a BMI of 34, here with the BMI being on the x-axis and odds ratio being on the y-axis, we found that at a BMI of 34, we start to see a statistically significant increase in the odds that the EFAST is going to be inaccurate. At the BMI of 34, the odds ratio is 2.05 with a p of 0.03. When assessing the EFAST exam completely, the BMI was 36 for the cutoff, with an odds ratio of 1.85 and a p of 0.05. It's important to note that there was no statistical association among increasing BMI and increasing odds of an inaccurate chest portion of the EFAST exam. So our EFAST was correct in about three-quarters of our patients, but sensitivity and positive predictive value were very low. And this is for a number of reasons. First of all patients who come into our trauma bay get EFAST exams. Therefore, this is primarily for training purposes, so therefore there is inherently going to be a low prevalence of injury. Also, the EFAST was performed by trainees. The FAST exam is like any other procedure. It takes time and practice to perfect. Also, using CT as reference identified minor injuries not detectable in the EFAST exam, such as tiny or minuscule hemothorax and pneumothorax, or a small amount of pelvic fluid. As previously mentioned, there is no statistical association among increasing BMI and increasing odds of an inaccurate chest portion of the EFAST exam. This is likely due to the fact that obese patients tend to show more abdominal girth than thoracic circumference, making the abdominal portion of the exam more difficult. So there are two main limitations of this of this paper that we really recognize. First off, our patient population was highly selected. All patients who are hemodynamically unstable were automatically excluded from our study because rather than getting CT scans, they went directly to the operating room. Also, we had weak statistical association with wide confidence intervals, and this is due to the fact that we had a few number of patients that were in the class 2 or class 3, which we classified as morbidly obese groups, yet we still did have 1/3 of patients in our entire study that were obese. So in conclusion, when analyzing the FAST results of 446 patients, while keeping in mind their BMI levels as well as other data that we collected, we've come to the conclusion that providers should use caution when analyzing the EFAST results in patients who are morbidly obese. And we do know that this needs to be confirmed in larger patient group and in other institutions. Thank you very much.